السلام عليكم جميعا ورحمة الله وبركاته. بعد أن أكملنا المحاضرة الأولى من البلفس and lower limb trauma اللي هي البلفس and acetabular injuries, we are going for the second lecture which begin with the dislocation of the hip. As we know, the dislocation of the hip have three types: the posterior, the anterior, and the central one. We begin with the commonest type is the posterior hip dislocation, also called the dashboard injury, which constitute about 90 to 95% of all hip dislocation. This occurs in road traffic accident when someone seated in the car is thrown forward, striking the knee against the dashboard. The patient in sitting position, the knee striking the dashboard, so the hip will forced out posteriorly, thrusting upward, and the femoral head is forced out of the socket, usually associated with posterior chip or piece of bone from the back of the acetabulum. It shear off, making the fracture dislocation. As I mentioned, it constitutes about 90 to 95% of all patients, usually occur in young patient as a result of road traffic accident. Clinically, the patient presented as shown in this picture: flexed hip, adducted, internally rotated, and slightly flexed, and the leg was shortened. Directly going for the X-ray in the AB and posterior view, the femoral head is out of the socket and above the acetabulum, as shown in this. The head is out of the socket. This is the dislocation, posterior hip dislocation. This is associated with posterior hip dislocation with the fracture of posterior wall. So this is a fracture dislocation, and this is the 3D reconstruction. This is the 3D view CT scan showing the posterior wall fracture and the head out of the socket. Classification of posterior hip dislocation is very important for ethical issues called Thompson and Epstein. We have 5 types. Type 1 is simplest form, is dislocation with no more than minor chip fracture of posterior acetabular wall. Type 2 dislocation with single large fragment of the posterior acetabular wall. Type 3 dislocation with comminuted fragment of posterior wall. Type 4 dislocation with fracture through the acetabular floor, more central. Type 5 is dislocation and associated with femoral head fracture or even femoral neck fracture. So this is the fracture dislocation and more complex one. This classification will guide the type of management and the future of the treatment, and also will guide the complication that may occur, including the degenerative osteoarthritis and avascular necrosis. Treatment of posterior hip dislocation. The dislocation must be reduced as soon as possible under general anesthesia or even sedation if the theater is not available. In the vast majority of the cases, this is performed closed. As we know, in the principle of the fracture or dislocation management is reduction, hold, and exercise. So the reduction either close or open. This type usually reduced in closed fashion. But if this not achieved after 2 or 3 trial, especially if associated with the fracture dislocation, so go for open reduction. Method to reduce is very important and should be to in details. We should have 3 persons: the assistant for anesthesia, the surgical assistant, and the surgeon himself. An assistant stays in the pelvis, support the pelvis on each side, and the surgeon start traction in line of the femur as it lies, and then gradually flex the hip and knee into 90 degree. This method called Ali's method. maintaining the traction throughout the maneuver. At 90 degrees of hip flexion, the traction is increased with internal and external rotation to pull in the head inside the socket. Sometimes need another assistant to pull out proximal femur, applying traction medially, then satisfying a clank which terminates the maneuver. After this, they complete the maneuver? No, we should check by telescoping movement. We should check the stability of the hip to guide the treatment, whether maintain the patient on traction or go for fixation of the posterior wall fracture. On this maneuver mentioned, so reverse the method of reduction. 90 degree flexion and posterior directed force to produce a telescoping movement at the hip joint. Complication, as we know, it's an early and late complication. The early complication, the hallmark is sciatic nerve injury, especially in fracture dislocation in around 10 to 20% of cases. And usually it is a neuropraxia type and recover spontaneously. Other is vascular injury, especially in the superior gluteal vascular bundle. Torn and bleeding may be profuse and may need vascular intervention. Also associated fracture femoral shaft in around 10 to 15% of cases. Late complication, in addition to general complication in early stage, general complication of an pelvis or acetabular fracture, which including thromboembolic phenomena, fat embolism syndrome, pulmonary embolism, and whatever, and cardiopulmonary collapse. Late complication, including avascular necrosis, especially in fracture dislocation, or neglected dislocation, which is delayed to reduce after 6 hours. Myositis ossificans due to profuse muscle injury and bleeding. A reduced dislocation after a few weeks, especially if the patient has head trauma, which may have missed posterior hip dislocation. Can seldom be reduced by close manipulation, so go for over reduction. Osteoarthritis, which is common and may be due to 3 causes: either from the start cartilage damage at the time of dislocation, or the presence of retained fragment in the joint, which is an indication for over reduction, especially hallmark in the CT scan. Third cause is the ischemic necrosis of the femoral head, especially according to the magnitude of the trauma and if delay reduction of the dislocation. Another type is anterior dislocation, which is uncommon and constitute about 5%. We have 2 types, either superior is the pubic type or inferior obturator type, according to the position in the X-ray. Clinical feature: reverse of the posterior hips. The leg is externally rotated, abducted, slightly flexed. It is not short, sometimes longer than the other side, because especially in inferior type, which is the obturator type. X-ray, as shown in this, sometimes we need the CT scan. Complication, the most important things is avascular necrosis in around 10% of cases. Central dislocation, which is associated with the acetabular fracture, when the greater trochanter is hit from the side and the head of the femur is forced inside the socket. It's called central dislocation. Another subject we go, is very important subject and very common you're facing in the emergency department, is the fracture of the femoral neck. The femoral neck fracture is the commonest site. The femoral neck is the commonest site for fracture, especially in elderly, such as osteomyelitic patient, diabetic, stroke, alcoholism, osteoporotic, and chronic debilitating disease. In addition, old people often have weak muscle, poor balance, resulting in an increased tendency to fall, even in the trivial trauma, which is the roll over the blanket. Very important things about the pathoanatomy and why the femoral neck fracture is important. Return back to the second stage about the anatomy. The femoral head gets its blood supply from the three sources. It's a very important point. Number one, intramedullary vessel in the femoral neck. Number two, ascending cervical branch of the medial and lateral circumflex anastomosis, which runs within the capsular retinaculum before entering the bone at the articular margin of the femoral head. And lastly, the vessels of the ligamentum teres, which is trivial and small vessel, but it gives supply to the head. It's very important points. Another important point which give the importance for the femoral neck fracture is the transcervical fracture. By definition, it's an intracapsular. Why this mean? This mean poor capacity for healing, and for this reason this is called the fracture of necessity. Why the femoral neck fracture have poor capacity for healing? For 3 points. Number one, by tearing the retinacular vessel, the injury deprives the head from its main supply. Number two, it's an intra-articular bone and only have flimsy or thin periosteum and no contact with the soft tissue, which could promote the callus formation. And number three, the synovial fluid prevent clotting of the fracture hematoma, which is very important step in the fracture healing, as you take it in the introduction. It's very important first step of the fracture healing is the fracture hematoma. Mechanism of injury of the neck femur usually result from simple fall in elderly patient, as I mentioned, very osteoporotic patient, and the force perhaps no more than catching the toe in the carpet and twisting the hip into external rotation. Some patients have unexplained experience minor symptoms of preceding, may have stress fracture of the femoral neck, repeated micro trauma which lead to fracture neck femur, while in young adults usually result from big trauma, major trauma, especially a road traffic accident or fall from height. The patient often have multiple injuries, and 20% there is an associated fracture of the femoral shaft. While the reverse, if the patient have femoral shaft fracture, around 5% of cases have associated femoral neck fracture. Stress fracture of the femoral neck may occur especially in runners or in patients with amenorrhea, especially in runners and military personnel due to repetitive microtrauma. Classification of the femoral neck fracture. The public and common classification would guide the treatment and the prognosis is the Gardner classification. We have 4 types. Number one is an incomplete impacted fracture, as shown in this picture. Incomplete impacted fracture, and so-called is an abduction type. Type 2 is complete but non-displaced. Type 3 is complete with moderate displacement, as is shown in this. Type 3 is severely displaced type. X-ray to delineate the stages and the classification, and this mentioned in details. We depending upon the proper AB view and sometimes internal rotation hip view for 10 to 15 degree to more delineate the fracture site, or sometimes external rotation film. Treatment of the fracture neck femur, as we know, is a fracture of the major bone, big bone, so assess the patient as a whole to exclude other injuries by ABCDE protocol. Initial management is the pain relief measures and simple splintage of the limb in traction, whether especially skin traction, to prepare the patient for surgery. There is no rule for conservative treatment in neck femoral fracture. Non-operative treatment and non-displaced type 1 and type 2 in dementia or surgically unfit patient. Otherwise is surgery. Displaced fracture in young age treated by 3 cannulated screw fixation in triangular fashion. In old age, Hemarthroplasty. This is called Thompson cemented type. Other type is Austin or more nowadays we used is bipolar arthroplasty. Or especially in old age with arthritic changes of the hip, we use total hip arthroplasty. This is the stabular socket, and this is the head, and this is the femoral stem. This hemarthroplasty, the stabulum, the nerve stabulum is maintained, and this only the head and the femoral stem. Complication of the femoral neck fracture, we have general complication, which include DVT, pulmonary embolism, pneumonia, and base sore. Complication of bedridden. Other is avascular necrosis, which is mainly related to the magnitude of the trauma. We have other point is the delayed treatment or imperfect reduction may cause avascular necrosis. Non-union, more than 30% of all femoral neck fracture fail to united, with many problems as you take it in the introduction by my colleague Dr. Abbas. Other is osteoarthritis. Avascular necrosis or femoral head collapse may lead to after several years to secondary OA changes of the hip. Other subject is very important is intertrochanteric fracture of the femur. By definition, it's an extracapsular. So the problems that related to the neck femur is not present here because it's an extracapsular fracture. Trochanteric fracture is united quite easily and seldom cause avascular necrosis. It's completely different from the femoral neck fracture. Divided into stable and unstable varieties. And the unstable varieties, by definition, is very important. It's very important. 3 points. You should take it in consideration perfectly. What I mean by unstable intertrochanteric fracture, we have 3 points. Either poor contact between the fracture fragment, as in this type 3 and type 4. Or comminution of medial cortex, as in this type. This is mean unstable fracture. Type 2, the fracture pattern is such that the force of weight bearing continually displaces the fragment, especially in reverse obliquity. Reverse obliquity, that I mean the fracture site begin at the lesser trochanter and return lower down. This means the muscle action will displace more. This means unstable fracture. Type 3, no osteoporosis leading to poor quality grip by the fixation implant. For ethical issues, the Kyle at 1994 described this classification in 4 types. You should have to know in details. 4 types according to the comminution and according to the comminution of the medial cortex. Clinical feature of intertrochanteric fracture. The patient is usually old, unable to stand, severe pain, shorted, external rotated limb, and the patient can't lift his or her leg. Treatment in general, it's almost always surgery. No rule for conservative treatment unless medically or surgically unfit patient. Why we should treat him early? Return back to the principle is hold, reduce, hold, and early rehabilitation is to obtain the best position possible for union and to get the patient up and walking as soon as possible, and thereby reducing the complication associated with the prolonged sitting. This modality of fixation available for the intertrochanter fracture. This is the dynamic hip screw, or called DHS. This is the dynamic hip screw with multiple interfragmentary screws, and this is the intramedullary nail or gamma nail or proximal femoral nail. Other modality is locked blade system, which is new, or biological blade called. This is proximal femoral anatomical blade. Complication of intertrochanter fracture, as I mentioned, is an early and late. Early, just like the femoral neck fracture, which is called occurred in elderly patient. Late complication, as I mentioned, it's unstable variety of fracture because the muscle action around the fracture site, and also it's in high stress area, transition between the horizontal orientation of the neck and vertical orientation of the shaft. It is in stress rising or high stress area. So the complication is failure of the fixation, malunion, especially varus and external rotation, and non-union. Even so, it is rare, but may occur, especially if delay fracture healing more than 6 months. That is all, and thank you.